Today we will talk about disorders or disease of neuromuscular junction. So to understand the disease of NMJ, we have to first of all understand the conduction at neuromuscular junction. So let's assume this is the presynaptic nerve terminal and this is the junction and this is the skeletal muscle. So this is skeletal muscle fiber, this is the junction and this is the presynaptic nerve terminal. And let's assume the action potential came here like, and with this what happens? Due to this action potential through these presynaptic calcium channels, calcium enters inside this terminal knob, and due to this the acetylcholine that is stored in these vesicles are released at these junctions, and these acetylcholine molecules starts acting on these nicotinic acetylcholine receptors and on these skeletal muscle fibers, and whatever the remaining acetylcholine molecule is remaining here after the contraction of the muscles is degraded by acetylcholine esterase enzyme. And you know that this junction is devoid of blood nerve barrier. So generally in our peripheral nerve we have barrier between blood and nerve. That's why T cells, B cells do not enter in our junctions. In the environment of peripheral nerves, or drugs, toxins generally do not enter. But here any toxins or drugs can easily come here. If patient is injected aminoglycoside, fluoroquinolones, then it can easily come here and interfere with the neuromuscular transmission. Or patient has botulism where ingest botulinum toxins, so this botulism can come here. Or in neurovenom envenomations like cobra kite poisoning, those neurotoxins can easily come here and interfere with the neuromuscular transmission. So let's take example of botulism. So here the botulism toxin came here and this is uptake by this presynaptic nerve terminal. So this presynaptic nerve terminal uptake that toxin and it engaged with these vesicles, and thus it interfered with the fusion of these vesicles with the presynaptic membrane and thus interfere with the release of acetylcholine. So if there is no acetylcholine, so there is no molecule to bind on these receptors, so skeletal muscles won't contract. So patient will have paralysis of skeletal muscles. And you know that in these envenomous poisoning or in botulism, initially the cranial muscles are first affected, then it descends down, like it is called descending paralysis, then upper limb muscles are affected and ultimately lower limb muscles are affected. So why does it affects like this? Starting from head and goes on down. But if you see in the limbs like upper limb or lower limb, proximal muscles are more involved than distal muscles. So in every NMJ disease, proximal muscles are more involved than distal muscles. I will tell you the reason later, but let's talk why the descending paralysis occurs in acute poisoning, either botulism or cobra kite envenomation. Because you know that any toxins enters in our venous stream, so initially it goes to from the vein to the right chamber of our heart, and it goes to the lungs and it comes back to the left ventricle, and from there you know that there is direct connection of this carotid artery, and it goes directly to the head and then goes to the upper limbs and then goes to the lower limbs. So those toxins initially got high concentration in the upper parts of the body and lower concentration in the lower part of the body, lower limbs. That's why you see the paralysis starts from up to down. So from cranial muscles are involved, patient have external ophthalmoplegia, diplopia, ptosis, then patient have swallowing problem, speaking problem due to paralysis of these muscles, skeletal muscles like masticatory muscles, facial muscles. And then patient will have proximal muscle involvement in the upper arm and then go towards the trunk muscles, then go to the proximal muscles of the lower limb, and distal muscles are affected at the last. So initially we get proximal muscle involvement in any type of neuromuscular junction disease like botulism, myasthenia or Lambert Eaton. So why proximal muscles are more involved than distal muscles? So you know that proximal muscles are bulkier muscles, big muscles. No, whether it is deltoid compared to these lumbrical muscles, or whether you see psoas muscle compared to foot muscles. So proximal muscles are heavier muscles, so it requires high action potential to reach threshold for muscle contraction. So let's suppose this is the psoas muscle, and this is the lumbrical muscle. Let's suppose. So this is the lumbrical muscle, this is psoas muscle. So here let's suppose these muscle fibers require 10 millivolt to cross the threshold for contraction of this muscle, and but these small muscles do not require that much threshold. So let's suppose this can contract only with 3 millivolt. This lumbrical muscle can contract, and there is any pathology like let's suppose myasthenia is there, or gravis or Lambert Eaton is there, or botulism is there. So what happens that this interferes with the acetylcholine release. In myasthenia, what happens? There is antibody against these post-synaptic acetylcholine receptors. In Lambert Eaton, there is antibody against presynaptic calcium channels, and thus interferes with this acetylcholine release. So whatever may be the pathology, the ultimate thing that occurs from all those is that the action potential in the skeletal muscle decreases. That's why it does not fire. So if the action potential decreases and it comes like here, let's suppose it becomes 4 millivolt, so it will not be able to reach the 10 millivolt threshold, so it will not contract. But here if it occur 4 millivolt, it is still crossing this threshold, so these muscles will contract. That's why proximal muscles are more involved than distal muscles in any neuromuscular junction disease. So we will talk about myasthenia versus Lambert Eaton myasthenic syndrome, myasthenia gravis and Lambert Eaton myasthenic syndrome. So here what is occurring? Here in the thymus there are myoid cells, muscle-like cells. It is called myoid. Myoid means muscle-like cells. So in those muscle-like cells there are nicotinic acetylcholine receptors, and antibody forms against those nicotinic acetylcholine receptors, and those cross attacks our skeletal muscles of other body parts. So the origin is from thymus, from these myoid cells. So these antibody cross reacts with the nicotinic receptors on our skeletal muscle. Here what happens that if it occurs as paraneoplastic syndrome, then antibody forms against a small cell carcinoma of lung, and this cross reacts with the presynaptic calcium channels of the nerve terminals. So here the disorder is presynaptic, here the disorder is postsynaptic problem. So here let's suppose this is the skeletal muscles, and here there are multiple nicotinic acetylcholine receptors, and some are blocked by antibody. So only few acetylcholine receptors are available to generate action potential. So these receptors may not be sufficient to generate sufficient action potential to cross the threshold to excite that muscle fibers. And here what happens that this antibody blocks these calcium channels, thus calcium is not able to reach inside, and if calcium is not able to reach in sufficient concentration of acetylcholine molecules cannot be released in the junctions, and thus if there are less acetylcholine molecules, even though there are many receptors, but since these molecules are only few, so it only bind on few receptors, so the action potential may not be enough to cross the threshold and muscle won't contract. So this is the difference in the mechanism of this disease. And you know that this myasthenia gravis affects initially starts from extraocular muscles, like patient have ptosis, ophthalmoplegia, and that is asymmetrical. Like Patient may have more ptosis on this side, less ptosis on this side, and lateral may have lateral rectus paralysis on this side, and may not, maybe this side may be extraocular movement in normal. So this is asymmetrical, and this starts from the eye, and it may remain in the eye in about 60% of the cases, and in 20% of the cases it can progress to involvement of other bulbar muscles, and in 20% cases it can progress to limb muscles involvement as well, these proximal muscles of the arm and leg. But in Lambert Eaton, it does not affect these cranial muscles generally. It affects the proximal muscles of lower limb. Here there are bulkier muscles. So generally it affects the proximal muscles of lower limb, and it generally does not affect these small muscles. So why the disease starts from the eye? Why ptosis occurs? Why external ophthalmoplegia occurs? Because there are few acetylcholine receptors on those muscles, tarsal muscles, on these external ocular muscles. So if there are less acetylcholine receptors compared to other skeletal muscles, what happens that if there are already less, and if you blocked even from those less receptors, so even more less receptors will be remaining. So due to less receptors remaining, what happens that these muscles will not be able to generate enough action potential to contract. So it generally affects first of all eye muscles, and then it can spread to involvement of these facial muscles that we express our facial expression, smile, sad, different facial expression, chewing, then swallowing, speaking. These oropharyngeal skeletal muscles, these helps in upper part of the oropharyngeal muscles, these are skeletal muscles, so those helps in swallowing, in the initial part of swallowing, and speaking, phonations, these helps in forming our voice that you are hearing with this talk. So these are basically small muscles, small skeletal muscles compared to these proximal or limb muscles. These are big muscles. So this starts with the small muscles, but it can also go towards involve other muscles generally. But this Lambert Eaton starts with proximal muscles of lower limb. I mean to say that it generally affects big muscles, and it generally spares these eye muscles, small muscles, but it can affect in the later part of the disease course, but generally it is not seen like that. And another thing about the difference between myasthenia and Lambert Eaton is that if you tell the patient of myasthenia to do exercise, what happens that he initially he can contract his muscle. Like if you say him to abduct his arm upward like this, so what happens that initially he is able to do like that, but after few moments he becomes tired and he is not able to contract his muscles. If I tell you to do like this 200 times, like go on doing like this 200 times, I did it and in 150 times my deltoid becomes feeling heavy, and I did not felt like I have enough power to raise my upper limb. So why does it occur like that? Because you know that in presynaptic terminal there are limited acetylcholine molecules in these vesicles, limited acetylcholine molecules, and with each contraction those are released. So if you go on doing contraction, what happens, those becomes depleted, and that's why the action potential goes on decreasing with repetitive nerve potential, and ultimately you won't be able to contract. So if you do repetitive nerve stimulation, if you go on repetitively stimulating this nerve, so you will see the amplitude like this, because this is the normal, this is of my deltoid muscles. This is normally also it depletes because those acetylcholine molecules are limited. So this decrement is normal. But in myasthenia gravis patient, what happens that these nicotinic acetylcholine, majority of them are already blocked with antibody and few are remaining here. So it becomes exaggerated here. So if you give one current here in repetitive nerve stimulation, if you give like one current here, it comes like this. If you give another current, it can come like this. If you give current like, it can come like this. So it dies fast because there are not enough receptors to generate action potentials. So if you see in the graph, you can get like this. So you can see that these two are able to cross the threshold of action potential. So with these two you got response, and this was not able to cross the threshold of action potential, so you don't get the contraction. So you can get like these two trends. So the difference between normal and this is that there should be greater than 10% drop. So difference between normal and diseased person should be greater than 10% to call that he has myasthenia gravis. And if you do this repetitive nerve stimulation test in Lambert Eaton, or tell the patient to do like this, so initially you will have difficulty moving like this, but as you go on doing like he will have improvement in power. Or if you give like repetitive nerve stimulation here, so initially you will see that he will have less action potential, but if you go on giving like his action potential goes on increasing. If you do this test in botulism patient with botulism, you will see the same response, because botulism is also a disorder of presynaptic junction. So in presynaptic problem, it goes on increasing. So why does it goes on increasing like that? Because these nicotinic acetylcholine receptors here are not blocked, these are functional. So if you give some current here, let's suppose you give 3 milliampere current here in this nerve terminal, and this is there were some presynaptic calcium channels already blocked, but whatever was remaining, it was able to enter calcium and it discharged some acetylcholine molecules, and this generated this response. But if you again give a current here, what happens again? It few released, and there is no block in these receptors. So again this will recruit more muscle fibers. So this is the physiology of muscle recruitment. If you go on giving current repeatedly, what happens that it goes on summating. It summates the initial action potential as well. That's why it goes on increasing. If the receptors, post-junction receptor are functioning, normally this occurs like this. This is called muscle recruitment, because initially 3-4 fibers are recruited, with again you give more acetylcholine receptors, on top of that more muscle fibers recruited, you again give potential current, again more muscle fibers are recruited. That's why if you sum up all the action potential of all the muscle fibers, the compound muscle action potential gets increased. So this compound muscle action potential goes on increasing. And you know that in Lambert Eaton there is autonomic involvement, but in myasthenia there is no autonomic involvement. So why autonomic involvement occurs in Lambert Eaton? Because the problem is in the presynaptic nerve terminal here, and you know that this presynaptic nerve terminal goes other parts of the body as well, like in our salivary gland, in our lacrimal gland. So there is presynaptic nerve terminal, and let's suppose this is the gland, and this releases some secretions. So here there is antibody against these calcium channels. So due to antibody, sufficient calciums are not able to enter it, and acetylcholine is not able to release here. So the muscarinic receptors that are present on those glands, there is not sufficient acetylcholine to bind, and those secretions will be dry. So patient may have dry mouth, dry eye, or this vagal nerve also innervates our heart. So patient may have tachycardia, abnormally tachycardia. Patient may have constipation, because those vagus nerve also innervates our GI tract. And you know that enteric nervous system, there is also acetylcholine molecules is also released from enteric nervous system. So everywhere the problem is in this presynaptic calcium channel. So acetylcholine will not be able to release, and the bowel will not be able to contract sufficiently. So constipation can occur. But here in myasthenia gravis there is no problem in the presynaptic. Here problem is in the only nicotinic acetylcholine receptors. Nicotinic only, no, not muscarinic. So here patient won't have autonomic symptoms. And in myasthenia gravis, with certain precipitants, a patient with myasthenia gravis ingest or take some drugs like aminoglycosides, fluoroquinolones, beta blockers, patient may have aggravation of symptoms, because this drug directly go to the neuromuscular junction, because there is no blood-nerve barrier, and this further impairs neuromuscular transmission, and there is already impaired neuromuscular transmission. So if I take these drugs, I won't have muscle weakness. But if those patients with already compromised, already blocked acetylcholine receptor takes these drugs, there is already low action potential in those groups of patients. So if we further impairs with these drugs, and the action potential further goes down in the post synaptic junctions, in the muscle fibers, so patient may have muscle weakness. And you know that increased temperature, if patient has fever, this aggravates his symptoms, because with increased temperature, what happens that if you keep a hot bag on this on my arm, what happens? The blood vessel dilates. Hot dilates blood vessel, cold constricts blood vessels. So when there is increased temperature of the body, what happens that blood flow to the neuromuscular junction increases, and so more antibody comes at that place, and so more antibody binds to the muscle junction postsynaptic levels. So patient may have aggravation of the symptoms if temperature rises. And in the opposite, you may be knowing ice pack test. So if patient has ptosis like that, and if you put some ice here or cold here, what happens that patient will have improvement in the droopy lid in 3 or 5 minutes. What is the reason? Because that also constrict blood vessels and antibody flow is less. And other mechanism is that acetylcholine esterase degrades the acetylcholine, so that enzyme degradation is also inhibited due to cold. No, so if more acetylcholine is available at the junction, and that improves symptoms. And you know, there is myasthenia gravis has fluctuating symptoms, like patient may have ptosis and it improves automatically, again has symptoms, it automatically improves. So why it is fluctuating like that? Because the blood flow is differing in different times of the day in our different body parts, because we are sometimes we exercise, sometimes we do some exertional activity, sometimes we take sleep, take nap during the day. So we do different activities, and during those instances blood flow into the various neuromuscular junction is also fluctuating, and due to that there is fluctuating level of antibody that is binding to the postsynaptic receptor. That's why symptoms are also fluctuating. Because what is the symptoms? Symptoms is actually the concentration of antibody present on the postsynaptic receptor. And as the day progresses, in the evening, patient may have aggravation of the symptoms like ptosis, double vision, or if limb are involved, patient may have difficulty moving limb upward, difficulty combing his hairs. So these upper head activities, when we have to move the limb upwards in the proximal muscles, patient may feel that he has more weakness as the day progresses. So why as the day progresses there is aggravation of the symptoms? Because as the day progresses there is depletion of the acetylcholine receptors in the presynaptic terminal. So let's take example. Today I woke up at 7 a.m. and yesterday night I had slept for 9 hours, and during 9 hours sleep I acquired about, let's suppose, 10,000 neurotransmitter molecules in my cortical and subcortical neurons. Those cell bodies of neurons synthesize, let's suppose, 10,000 neurotransmitters, some GABA, some glycine, some serotonin, some norepinephrine. And since morning till now 7 p.m. vast majority are depleted and few are remaining still, and that's why I am able to communicate you, I am able to give my attention, you know. But as the night progresses, like 12 night or 12 am occurs or 1 am occurs, what happens that those neurotransmitters got depleted. And again I have to sleep to again during sleep the cell bodies again start synthesizing neurotransmitters, and tomorrow morning I will again wake fresh and I will able to talk with you and I will able to give attention completely. because I will again have repletion of those neurotransmitters. So similarly, as the day progresses, what happens that the presynaptic terminals in this acetylcholine vesicles, those also goes on depleting, and since there is already compromised post-junctional receptors because antibody are blocking, and as the day progresses these molecules also go on depleting, so patient have aggravation of the muscle symptoms in the evening. So what is the treatment of myasthenia? If patient has thymoma, we have to resect it, or even if patient does not have thymoma, we just have to remove the remaining thymus tissue, because the source of the antibody production is the thymus. So if you can remove the thymus, what is seen in studies that patient goes into remission. Patient may not require immunosuppressants. Patient may not require pyridoxysteroid to alleviate symptoms, because the origin of those antibodies are thymus in majority of the cases. So if patient's age is less than 50 years age and patient having generalized muscle symptoms, muscle weakness, so we can do thymectomy even if there is no thymoma. So whatever thymus is remaining, we first do imaging of those thymus with MRI or CT, and we remove those remaining thymus, and patient can go into remission. And for symptomatic treatment, we give pyridoxysteroid. Pyridoxysteroid, what is pyridoxysteroid? This is acetylcholine esterase inhibitor. So let's talk about this inhibitor. What happens that if you give in myasthenia gravis also or Lambert Eaton, in both cases this will improve symptoms. This both will improve symptoms, because what is the mechanism of this? Because this inhibitor inhibits the degradation of acetylcholine. So acetylcholine concentration increases in the junctions, and whatever the antibody are already binding at the postsynaptic nicotinic receptors, some acetylcholine will displace that and it will bind it, and the patient may feel that temporary improvement in symptoms. If you give pyridoxysteroid in 15 minutes, patient will have improvement in ptosis, patient will have improvement in double vision. And the effect of pyridoxysteroid does not last long, like 3 to 4 hours or 5 hours, like that only. So we have to dose it frequently, like 4 hourly, 6 hourly we have to dose it. And we initially start with low dose like 30 mg TID and goes on increasing the dose based on the improvement in symptoms, how much symptom has improved. So we can titrate it upwards based on that. Why do we dose at low dose? Because patient may have muscarinic symptoms as well. So if you inhibit the acetylcholine esterase, so this will also inhibit the degradation of acetylcholine muscarinic junctions. So patient may have siluria, because there is muscarinic receptors in glands. Patient may have diarrhea, because there is muscarinic receptors in GI tract. Patient may have cramp due to increased peristalsis. So to avoid muscarinic symptoms, what we do that we start pyridoxysteroid with glycopyrrolate. So what does glycopyrrolate do? That it inhibits the muscarinic receptors. It inhibits muscarinic receptors but not nicotinic receptors. So patient may feel improvement in the skeletal muscle power, but patient does not have such symptoms of siluria, diarrhea or cramping abdomen.